Hi, I'm Dr. Michelle Dew, General Cardiologist with AdventHealth Shawnee Mission. I'm going to share some quick information today with you because February is American Heart Month, and 1 out of 4 Americans dies of heart disease every year in the United States. I have a special interest in women's heart health and am building a women's cardiac care program here at Shawnee Mission. I'm going to talk about hormones today, not just in relation to our female patients, but also in regards to our male patients, coronary artery disease, and testosterone replacement. Hormones in the heart rules pretty easily off the tongue, but I will tell you that these two topics have caused lots of consternation, especially when used in conjunction. Starting with our women patients, in general, there are 3 times in a woman's life when drastic hormonal fluctuations occur. Menarche, which is the onset of menses, pregnancy, and menopause, also known as ovarian retirement, no longer producing estrogen. As is well known, the body's cycling of estrogen and progesterone can cause many symptoms, which contribute to premenstrual symptoms, some pregnancy symptoms, and more than 100 documented perimenopausal and menopausal symptoms. The key is to be aware of when in a patient's life she comes to you with cardiac symptoms, so that you don't overlook the potential contribution of hormones to heart disease and symptoms that can mimic heart disease. Okay, 1, around menarche, young women can present with fainting, palpitations, tachycardia, many times identifying what exactly the patient is eating, drinking, and using for recreation can elucidate etiology of symptoms, or at least give you a direction for recommendations. Sometimes just paying attention to when the symptoms occur in relation to menses can really give you an edge on reassuring patients and anticipating and managing symptoms. 2, as you well know, pregnancy is very complicated. Symptoms that can occur during a normal pregnancy can be the same as someone with heart failure. Postpartum cardiomyopathy is thankfully relatively rare, occurring in about 1 in 1,000 to 4,000 deliveries in the United States, but can be absolutely devastating. In general, there are decent rates of recovery with postpartum cardiomyopathy, but early recognition and diagnosis is key. Maintaining a high suspicion of potential cardiac issues with atypical symptoms after delivery is essential. FYI, a diagnosis of postpartum cardiomyopathy is not an automatic contraindication for repeat pregnancy. Of course, high-risk obstetrics and cardiology should be on board for ongoing recommendations with these patients. Finally, my pet project, menopause in the heart. Some of you may remember the 2002 Women's Heart Initiative study abruptly being halted when an increase in breast cancer and heart disease was reported in the hormone replacement therapy patient arm. This study was originally designed to look at breast cancer and heart disease outcomes in women with hormone replacement. This publication and the ensuing press led to an almost immediate discontinuation of hormone replacement therapy in millions of the women in America. It is important to remember that there were many evidence-based research trials prior to the Women's Health Initiative illustrating both protection and improved outcomes with cardiac health with HRT. There has been a lot of scrutiny in regards to the patient population in the Women's Health Initiative, and consideration that the patients studied did not represent newly menopausal women. A good percentage of these patients in the Women's Health Initiative were smokers, overweight, and had hypertension. Also, importantly, was the fact that the average age of the patients in the Women's Health Initiative was 63 years old, and in general, hormone replacement therapy was started more than 10 years out from menopause. Turns out that blood pressure increases and cholesterol levels increase with menopause and estrogen decline, and about 10 years after menopause, women patients catch up to the men with rates of cardiovascular events. There are a lot of opinions about hormone replacement therapy, but in regards to heart health, review of the evidence suggests that if a woman is started on HRT within 10 years of menopause or before the age of 60, the benefits to heart health outweigh the potential negative effects. I am very transparent with my patients that not everyone is a candidate for HRT, but that a serious discussion with their primary medical provider or GYN is warranted to get to the best health recommendations for heart health. With all of the social media, celebrities, and news outlets sharing information, I anticipate that you all will be getting more questions in regards to HRT. It is a rare day in my clinic that hormone replacement therapy and cardiac symptoms and issues do not come up. From a cardiovascular perspective, we do not start or stop hormones for cardiac reasons. There is a great book, Estrogen Matters, by oncologist Avram Blooming and psychologist Carol Tavris, that takes a deep dive into the flaws of the Women's Health Initiative and looks at the many beneficial effects of HRT. I highly recommend this scientific-based book and think it may provide you with some helpful insights. Okay, now let's talk about men, heart disease, and hormones. I get frequent questions about whether testosterone replacement is okay in a male patient with a history of heart disease. And the answer depends. If the patient is stable, has good control of cardiovascular risk factors, not having angina treated with nitroglycerin, and has not had a recent event which would include myocardial infarction, angioplasty, or surgery, then testosterone replacement is probably okay, as long as they are followed closely by the prescriber, whether that's primary care, endocrinology, or other. In 2002, the New England Journal published a study in regards to testosterone replacement in more than 5,200 middle-aged and older men with hypogonadism, which revealed that testosterone replacement therapy was non-inferior to placebo in respect to the incidence of major adverse cardiac events. And of course, if a patient has had success with or wants to try one of the phosphodiesterase type 5 inhibitors, including Viagra, Cialis, Levitra, and others, then it's probably okay to continue use as long as the previous criteria are met. There's no chest pain with use, and especially no nitroglycerin use within 48 hours, including short-acting sublingual, but also long-acting preparations like isosoravide or Isodero. So for now, that's your quick little wink of information regarding hormones in the heart for this Heart Month. Lots of more things we could talk about, but for now, happy Heart Month.